gives me great pleasure to introduce our keynote speaker this evening. Celia Falicov, PhD, is an internationally renowned family therapy author, teacher, and clinician. She is clinical professor and founding director of mental health services at the student-run free clinics in the Department of Family Medicine at the University of California, San Diego. This academic community partnership program is composed of volunteer psychiatrists and psychologists who serve undocumented and uninsured Latino immigrant families at 3 free medical clinics. In this setting, she teaches medical students to integrate mental health issues with culturally sensitive and socially just practices. Dr. Falicov was born and raised in Argentina, received a master's degree in clinical psychology from Loyola University in Chicago, and a doctorate in human development from the University of Chicago. She is a past president of the American Family Therapy Academy. Dr. Falicov has pioneered extensive writings on family transitions, migration, culture, and context in family therapy practice and training. She has received many professional awards for this work and serves on the editorial boards of several journals. Her books include Family Transitions, Continuity and Change Over the Life Cycle, Cultural Perspectives in Family Therapy, and the co-authored Multiculturalism and Diversity in Clinical Supervision. The second edition of her book on Latino families in therapy presents important conceptual and practice advances with a wide range of useful case illustrations. I would say, as impressive as her academic accomplishments indicate, I think probably her biggest accolade is her work, hands-on work with people who are underserved. She has a warm, compassionate heart, and if you partner that with her academic excellence, we are indeed honored and privileged to have her this evening and tomorrow.
Thank you so much, Suzanne, for this heartwarming presentation that you've done of me. And thank you all for inviting me. And I hope you can hear me well. I tend to have a low voice, so the people who are in the back, then I can't see you because of the lights. Please come closer if you can hear me well, or just tell me, speak up, okay? I have to say something about the invitation to come here. It was a very kind invitation that Dr. Suzanne Coyle wrote to me about speaking on this topic, and the topic of basically integrating spirituality and social justice in care. And so my first reaction was, but that is not what I do. I could not possibly talk about spirituality. And her answer was very calm, was very peaceful. She thought, if I said it in Spanish, she thought something like, yes, sí se puede, which is what Cesar Chavez actually said to the farm workers about forming a labor union. And so she was referring to my dedication to mental health services for Latino, underserved and under-resourced immigrant clients, a work that I've done for many years now. And I had not really, I understood the social justice part, but I had not connected it with spirituality. And so it appeared to me as a tough link. So, but it was very thought-provoking. So, and I think I've learned a lot in the process of thinking about it. And I want to ask you, think to yourself briefly. You can write it down if you wish. What comes to your mind when you hear the word spirituality? You probably are all a lot more experienced than I am with the word itself. And then also what comes to your mind when you hear the word social justice. My invitation is sort of do what Buddhists say, first thought, best thought. And so just if you care to write it down, perhaps you will revisit these words at the end of my presentation and see if it fits in any way with your own conceptions about what spirituality and social justice are. And so I will tell you what kind of summary of the words that I have come up with in my readings and my thinking. And I know that the word spirituality means breath, that comes from the Latin, and that is a quest for meaning based on values, love, compassion, peace, solidarity, justice. Today, talking with Suzanne, I realized that I should have actually also probably put the word transcendence. And it's connecting with adversity, appreciation, the oppression of humanity in many different ways. How do we connect with human suffering, both in theist and non-theist ways? And social justice, is fair treatment, right? And equity for all individuals and groups in a society, working to undo social inequities and create a society where human rights are given to everybody. And so, and religion, if we were to add that, is probably to organize. Being a part of a faith community solidifies spirituality into sacred scriptures, doctrines, rituals, and rules of conduct. So let me just give you a little statistics about how much spirituality Americans say they have, according to polls of the Pew Center. So I think I'm in the same place as you are, yeah. 83% of US adults believe that people have a soul or a spirit, which is a very large number, right? 81% say that there is something spiritual beyond the natural world. And 7 in 10 describe themselves as spiritual in some way, including 22% who say they are not religious. So what does it mean to be spiritual in some way? Well, if you explore that, again, statistically, people define spirituality as being connected with something bigger, being connected with God, being connected with my true self, and smaller numbers also say being open-minded and being connected again with nature. And I see that I did not highlight the last one, being connected with other people, but you can see how many times the word connection is being used. And so the first thing we could say is that spirituality brings connection, that this is the main theme that helps us link it with social justice and spirituality together. Connectedness through many things, kindness, compassion, empathy, help awareness of injustice, right? And prompts action to right the wrongs. So the application spans many, many fields, like you're aware, right? Environmental justice, medical and mental health, civil rights, racial justice, economic justice. I will try to organize my thinking today in what I know best, which is in the health and mental health fields. So let me locate myself first. I have worked for many years in community mental health in La Frontera, which means the border between Mexico and the US, which is the Tijuana-Mexico border. It is the busiest border in the world. People cross through the desert to escape dire poverty or violence and to ask for asylum from gangs, drug lords, and extortions from Mexico, Honduras, Guatemala, and now also from Venezuela. Extreme poverty, individual, social, institutional, and state-based violence are the drivers. So the traditional idea of immigrants, particularly economic immigrants, being voluntary is somewhat questionable. There's a big division in the field about what's the difference between immigrants and refugees. But many of our what we call immigrants, particularly undocumented immigrants, are really refugees, from very, very difficult situations. And because they're undocumented, they constantly leave with the fear of deportation. And the failure of family reunification policies in the United States has contributed a great deal to the traveling undocumented. So I will try to, because this is a very big topic, I will try to organize it with a model that I learned in graduate school, and that it continued to be very helpful to me. And that's a model that was developed by a developmental psychologist called Uri Bronfenbrenner. You probably are very familiar with it, that proposed an ecological systems theory model that uses 3 levels: the relational, the community, and the cultural diversity and structural inequality level. And those in that theory, systems ecological theory, they're called the micro level, the meso level, and the macro level. So I will start with the micro level, or the relational level, and with an experience that I witnessed at the relational level years ago. But that every time that I revisit that experience, I do learn how much was involved in it, that one could learn from it. So it was an encounter with a Latinx immigrant family in a hospital setting. It was an experience that illuminated for me the importance of culture and context in the relationship between providers, which could be many types of providers in the mental health or the health field, and their clients. So as a bilingual psychologist, I was consulted, mostly as a translator, in a hospital that was just across the street from the Neuropsychiatric Institute where I was working. And it involved a 7-year-old boy, Ricky, who had recently been operated for a congenital heart disease. His great aunt, an elderly Mexican woman of color, was in the room next to him, praying, clutching a rosary. The nurses and doctors had really come to dislike her very much, blaming her for slowing down the child's recovery. That's really what they wanted me to say to her, that she was bringing greasy food into the hospital when there was healthy food to be had, instead of feeding the child that she was fatalistic by praying, and that she did not activate him enough. Because, and probably they were right about that the child needed to be moved through the corridors to energize him after the operation. And so, and a consulting psychiatrist had already been called, and because he was not Spanish speaking, he just simply went by what he was seeing. And what he was seeing was that this woman was overprotective of the child, in his view, and that he thought that perhaps there was no biological mother on site, and this great aunt was the only family person that had been there for several days, that maybe the great aunt's overprotectiveness had to do with her feeling overburdened at her elderly state and age of having to take care of a young child, and that maybe it was an unconscious reaction formation against her negative or hostile feelings towards the child. Well, so we have now the characters, right? Ricky, a 7-year-old boy, Soledad, who is probably 60 years old or maybe older, the hospital staff, which I already described, and myself, right, as a translator and conveyor of messages. So this was really an encounter of diverse cultures and structural locations that need to be understood and compared. So if we can reflect on these 2 areas, we can reflect on what are the issues of cultural diversity, values, beliefs, customs, rituals, worldviews of this encounter between professionals and Ricky and his great aunts. And what are the issues of structural inequality in terms of resources, power, status, privilege between the professionals and the great aunt and the child. Although they interact, they are different, these two areas, but are often conflated, which creates some confusion. I used to say sociocultural or sociopolitical until recently, and you will hear me sometimes using them interchangeably, but more recent, the word structure, which really comes from the social sciences, is used more and more within family therapy and other fields because structures involves class, race, and gender, or the organization of the economy, which forms the class structure. So if we compare both, and that's what I'm going to do, compare cultural diversity in this encounter and compare structural inequality in this encounter. So if we compare cultural diversity, Ricky's great aunt brings to the encounter religion, ethnic foods, a protective parenting style. While the hospital staff brings medical pragmatism, probably most likely secular, institutional healthy food, quote unquote healthy, probably very boring, right? Compared to tacos or tamales, or, which the great aunt intelligently brings it to the child, and they also want physical activation, and the psychiatrist is using a mainstream model of a healthy mother-child biological relationship as the healthiest. So then if we look at the possibility here is that the alienation and the conflict between the hospital staff and the great aunt was no doubt due to different models of family life and age-appropriate expectations in dealing with a sick child. And so then we have a situation where spirituality and religion and the praying is labeled as fatalism, as being sort of against the optimism of an American hospital. And then ethnic food is considered greasy, spicy, unhealthy. And the lack of physical activism is called passivity, overprotectiveness, and pampering, right? So, and the combination of all these things made the psychiatrist look for an unconscious reason. And so I learned that cultural misunderstandings take place even more seriously in situations of stress for all parties. I have many examples that I can give you if we have time for, where people can sort of get along okay, but then in a situation, even if they're neighbors, but then in a situation of stress, they turn against each other. And so my message is that nobody was a villain. Everybody was under a lot of stress. I try to think compassionately about all sides. I do not think our work as finding blame. So the child was dying. And in every case, we can find universal similarities and be compassionate. When a child is dying, that's a universal human tragedy. And most likely, people feel universal human emotions of grief and dismay. This should not be happening. A child should not be dying. It's our shared humanity, right? But then there's also cultural specificity in that encounter. The medical encounter is stressful for both patients and doctors. So everybody was using the concepts learned in their cultures to cope. By and large, doctors work tremendously hard and care a lot about their patients. But if we compare the structural locations of the great aunt and the hospital staff, we can appreciate that there are many things that disfavor Ricky's great aunt. Her race and color, her gender, her class, her education, her immigrant status, her language, and her age. And so she's powerless to complain. There is a power dynamic here based on race, color, class, gender that makes her unable to ask for a second opinion. It's a free service. And so a middle-class mother in this situation might say, doctors, my child is really not doing well, and you're saying that he's failing to thrive. Could we have a second opinion? No? So this great aunt cannot say to the doctors, please, let's call this a second opinion. Right? Even white people have a lot of problems with asking doctors for a second opinion because of the authority that it carries, right? So, and what happens in the hospital staff is that they feel in this situation in most situations, entitled to diagnose. But sometimes being entitled to diagnose means blame the victim of oppression. So the doctors were suffering too, but this does not excuse them from their professional responsibility to try to be more equitable in situations of inequality. And so let me ask you, because that's actually one of the things that we try to do with the medical students, what is the difference between inequality and inequity? How many of you know the difference between these two concepts? I can't see you because you're so dark in relation to the lights, but if you raise your hand, maybe I'll be able to see if you know what the difference is between these two concepts. I think the professors in the school know. Yeah. Yes, yeah. Yes, I can see that. Okay, so it's wonderful that you know it. I only learned it some time ago, Yeah, good. Yes, the students too. So I only learned it some time ago as I was using them interchangeably for a long time, And so I learned it actually from my youngest daughter. Her name is Anna. So when she was in law school, she went with her class to Thailand. It was a very nice professor that they had at the University of Buffalo, took them to Thailand to learn about Buddhist law. And she came back, and then she told me that the Buddhist judge in Bangkok, where they were, asked them a question. And the question was, does a heavy-set large man need the same T-shirt as a thin small man? And the answer is no, absolutely not. Equality is giving both the same T-shirt, but one can use the T-shirt and the other cannot. Or the other, it would be too big. So equity is giving each the T-shirt that fits their physiques. And that is justice, okay? And so you probably have seen in the internet this painting, which I thought is very good, that is the difference between equality and equity is that in the equality drawing, each person is given the same box. So what happens? The resources are spread evenly. So look at that situation. When resources are spread evenly, in that scenario, the shortest person cannot see over the fence, and the tallest person can see even more over the fence than before. In the equity one, in the drawing, the people are given 1, 2, or no boxes to stand on, meaning the resources are spread according to need. So that's what's being fair or just, the second picture. So granting women equality of rights and salary is very important. It's absolutely fundamental. But equity takes into account that women are not in the same starting position of men, not only because of historical prejudice and social disadvantages, but many even current constraints, such as maternity, availability of daycare centers, or just simply who takes care of children, even in two-people marriages. So, and women of color have even greater constraints of economic resources and childcare than white women. But let's go back to Ricky and his great aunt, because I think we have probably more to say about this issue of equality and equity. So actually, if we look at what's happening in the hospital and the operation, I think we could say that the hospital care the surgery, the doctors and the nurses' dedication, and the hospital bed and the number of days and the standard food was pretty much equal between a brown boy and probably a white boy. Yeah? But was there equity? What would it mean to have relational equity in this situation? So think for a minute about an answer before I give you my answer. Think equality was given. It's one of those rare situations where this medical school is very responsible and was giving equal care. But where was the lack of equity? And so I tell you what my answer is, and I think I can make it here. Yes, that I believe that the doctors were demanding acculturation to the mainstream culture as the only healthy alternatives. Remember, they were all under stress. They were saying, no, give him the hospital food. Walk him, don't overprotect him. Don't pray. Don't pray because that means that you're very pessimistic, right? And so many studies point that cultural preservation, particularly in situations of stress, are part of resilience and better mental health outcomes if you are honored and respected. So we need to understand the value of cultural preservation as a form of justice. So let me ask you now, and I think I'm going to move from the light so I can see you again, because I'm a little bit worried now that I'm presenting this, and I think, oh, maybe you all already know this, and you're going to say, what is this lady trying to tell us? Because, yeah. So this happened a long time ago. So can it still happen today? So you can say yes loudly so I can hear you, and or raise your hand and tell me, do you think it could happen today, or are we past it? Are we in a place where this misunderstanding of the encounter of cultures and social locations can happen today? Would you say yes? Yes, okay. It can happen, so it cannot happen today. Can you say no loudly? You're saying yes more. I can tell you, in my first book about Latino families in therapy, I started with this case. And in my second edition, I didn't, because I thought we're past it. But every time I present it, people say, no, we're not, no? But I think we have made progress, but how much progress have we made from this type of, say, cultural and social and relational injustice? So do you think, and you can say, when I say a lot, have we made a lot of progress? Can you say A? No. Can you say B somewhat? Yes. Good. Have we made no progress? C? No. So you all think, the majority of you think we have made some progress. I agree. Okay? And you might say, what is missing in this encounter? What was missing in this encounter? So you're going to probably say cultural awareness was missing, okay? Sort of like cognitive open-mindedness, that there are different ways of dealing with a sick child, or dealing with many things, dealing with food. Would you say that cultural sensitivity was missing in terms of feelings and emotions for people of other cultures? Probably, yes, yeah. Can we say that cultural competence was missing as knowledge and skills about other cultures? You probably are going to say, yes, cultural competence was needed. Was structural competence missing in terms of different social classes, different social locations, different levels of power between hospital staff and the patient? The answer is probably yes. So this would be our first answers. They're not wrong, but I think they're incomplete, okay? And I think I will spend a lot of time in the next, today and also tomorrow, talking about the limitations of cultural competence, the way that we have been using it. So let me ask you now, would acceptance of spirituality and religion in the practice encounter facilitate social justice in this case? And I think my answer, it would be yes, if as part of cultural competence, you say, well, some people are religious and some people are spiritual, it would create more acceptance, right? More acceptance, more tolerance for diversity about others. But would it lead towards a transformation of services? That, I think, it would be harder to do. So being respectful in allowing the great aunt the dignity of her praying and loving her child would have been humane, right? But a deeper transformation, however, would require more of a courageous engagement on the part of the hospital staff to provide cultural safety. So cultural safety is somewhat different than cultural competence. So what do I mean by courageous engagement and cultural safety? Well, a courageous engagement on the part of the providers, in this case physicians and nurses, but it could be social workers, therapists, priests, ministers, teachers, would be to provide cultural safety through cultural humility. So, and I'm going to be talking, if I don't know how much time I will have at the end today, but certainly tomorrow I will really talk about cultural humility. And so what is cultural safety? Well, cultural safety is whether you know anything about the culture or about the other people's culture, you have to minimize any assault on the client or patient's cultural identity. You may not know anything about Muslim people, nothing at all, right? But it doesn't mean that you have to, in some way, utilize your lack of knowledge to say that's wrong what you're doing, okay? And not blame the victims of historical and social oppression for their current plight. And you have to engage on services that where the safety, the cultural safety, is defined by the people you serve. Very hard to do, but I think it is underpinned by a social justice framework. It's not so much about cultural competence as content, but as a process of personal reflection that recognizes diversity and inequalities in the clinical encounter itself, and it recognizes that white culture is a culture, that white people have a culture too. So that it isn't only about the others. You have to reflect on what are the terms of your own culture. And that's what cultural humility means. It's cultural safety and cultural and structural humility, because cultural humility alone would indicate knowing something about the customs, the rituals, the belief systems of other cultures. But structural humility is also putting the power dimension into it. I think several of the people who presented me, Dr. Coyle, mentioned that I work in a medical setting. And actually, you would be surprised about this, but the concept of cultural humility, the first article published on cultural humility was in 1995 within family medicine, not within family therapy, within family medicine. So, and that why is because it requires a mutual interaction where the practice encounter is, you recognize that it's not neutral, that it's culturally diverse and structurally unequal. So the patient or client, individual or family, brings their cultural diversity and their social location to the encounter, and so does the practitioner in terms of their theory, their training, their lived experiences. It is not an encounter among equals, and for several decades, there has been a preoccupation on how to treat clients from other cultures, and many people have received ideas about cultural competence about others, and much less about their own cultures. all right, but much less about the culture of institutions. So cultural humility demands self-reflection about your own class, race, cultural beliefs and voices as a practitioner, and knowing that your professional view is not necessarily the only right one. It means a non-superior, a non-judgmental perspective, an awareness of power dynamics, and ultimately it means that the clients are the experts in their own culture and context. I mean, I think this great aunt could have been asked, it's like, do you think the child will eat this food? And they most likely, the aunt who is the expert on the child's liking of food, she will say, no, he will never eat this boring Jell-O, but he will eat something spicy and flavorful, right? So let me give you a very brief illustration of cultural humility with immigrants. It happened several years ago. I had to do a presentation in Zurich in Switzerland. And I came across a flower shop that at that time of the year had lilies of the valley in the window. And that's one of my favorite little white flowers. So it occurred to me to do something just before my presentation. So I bought 3 little pots. And in one pot, I kept the plant in its pot. In the second one, I uprooted the plant with some soil around the roots, as that would facilitate the transplantation, as most good gardeners know. And like the third one, if you cut the flowers completely, they look pretty in a crystal and a glass vase for a while, but they die, right? They don't stay for more than a few days. So a pastoral counselor was in the audience and approached me and asked me if he could borrow this metaphor for his next Sunday sermon. And he said that up to this presentation, he had about immigrants, that he had always thought that the faster immigrants assimilated in terms of language and cultural know-how, the better off they would be. But then now, with some cultural humility, he recognized that perhaps he was asking them to cut off their roots. And that was an incredibly humble insight on his part, I think. Now, to realize that, yes, it's Switzerland, it's a perfect society, right, from his point of view. Why couldn't people assimilate to it? Yeah? And so his own cultural structural humility, I think, involved a relationship with other people that honor their belief, their customs, some self-exploration and self-critique about the power to impose one's views on others, and a non-judgmental way of being and not just doing relationally, right? That's what we always tell the medical students. It's about people are going to remember how you are, not only what you say or what you do. So it's striving to find bridges of human connectedness. So why was, you would then say, well, is it because I'm Argentine that I speak the same language? Well, maybe, but it's a complex system of several cultures. The patient and the family, the pediatric cardiologist, the nurses, the psychiatry. So let's look at my own lived cultural and structural experiences that at the relational level, they become cultural borderlands. And you will see how I try to connect cultural borderlands with what I was saying before about courageous engagement. So if we compare my ecological niche, which is sort of a thick description about multiple cultural and social locations, if you look at the orange areas of similarities that I had with a great aunt and the child, in terms of being able to speak the language and being able to have a Latin American ethnicity, and being able to both probably be women with gender identity that was very traditional, and we both, parenthood. I had been a widow for many years, raising children by myself, so we had experience of single parenting, and then we were both immigrants, right? And if we look at the yellow ones, they're different. They're very different in terms of socioeconomic status, education, religion, but the differences in yellow, so the difference in orange allowed me to connect with her. But the differences in yellow allowed me to stand in between because I could share borderlines with the medical system. My husband was a physician. I'm white. I'm a bilingual professional with a doctorate. I understand urban settings. I had some cultural contact, with a great aunt, but my social status gave me power that she did not have. So cultural borderlands or other lived experiences can bring connectedness and even, say, a common ground that allows for courageous engagement when we witness injustice. So what is courageous engagement? I think in our case, it's mostly through difficult conversations between parties, but maybe there are other situations. What are courageous conversations? Well, they're usually initiated to discuss issues that are difficult and uncomfortable, such as systemic racism or colorism or barriers to women in leadership or anti-immigrant positions. So emotions are often high. It was not easy for me, as a psychologist, I'm also, as a psychologist, lower in the hierarchy than physicians. So it was not so easy to say, wait a second, here, I don't think there's a clear understanding of what's happening in this situation. So these conversations can be embarrassing, awkward, and just plain stressful for everybody involved. So they take courage, and they require openness and authenticity, calmness and honesty to make it work. So, but if they do work, and like in my case, courageous engagement, it was to find not only the cultural borderlands, but the bridges of human connectedness, like saying, we know that all of you are suffering because a child is dying, right? And so this allowed honest conversation with the doctors and nurses and suggesting some sort of relational repair towards the great aunt as accountability and as social justice. So what do I mean by relational repair? Ricky died a few days later, and his death was inevitable. There are many children with congenital heart diseases that surgery is attempted. Usually it has to wait until they're about 6 or 7, and sometimes it doesn't. In this case, it was a pulmonary embolism that overtook his lungs, and so. But the great aunt had been judged quickly, harshly, and in an unfair manner, in a really not equitable manner. Much suffering could have been spared if she was understood culturally and spiritually. So the psychiatrist gave a pathologizing diagnosis of the great aunt's loving caretaking without asking about the mother's absence. And so relational justice or ethics could be defined as truth-telling and dialogue in a post-conflict situation that are not easy, but they but show the intention of repairing injustice. So I want to move to the meso level, to the community level, but first I want to say that sometimes witnessing injustice as a young child leads to spiritual connections and courageous engagement. So again, I have here, structural inequality, cultural diversity, and comparing ecological niches. And and I have a little book there, right? And of Paulo Freire, the educator, author of many books, but probably in the United States, he's best known by Pedagogy of the Oppressed. And he was Brazilian, deeply religious and spiritual. And as a child growing up in Brazil, from a fairly well-to-do middle-class family, he was very, very upset about how his grandmother, who was white, treated a black maid. And he told his parents, he was 6 or 7, and he told his parents how angry he was about his grandmother. And like, why does she treat, this woman who is so wonderful, who's like a second mother to me, and she treats her so badly? So his parents said, okay, we'll talk to the grandmother because you're upset about that. And apparently, after he said this, then his father, because then his wife wrote a book, after his death, and said that his father predicted that this child, Paulo Freire, was going to be a subversive, and because he was from a young age understanding what was unfair treatment, And so Freire loved being called a subversive, he said, and he loved it more than being called a revolutionary, he said. So as an adult, he became determined to find a methodology to empower impoverished and illiterate people through literacy. And so the reason that I'm using this example is because relational experiences of connectedness then can become drivers of social justice in larger ecological settings like community. Many of my friends, probably myself included, have been inspired towards social justice work by witnessing relational injustices from a young age, such as violence towards people of color. So let me now move to the meso level of community and talk about and the people that I work with. The health and mental health stressors of undocumented immigrants in the community are many. They live in the dark, they fear deportation, and many losses, because only some people in the family may be deported. They're discriminated against. They have long-distance and short-distance isolation. They lose a lot of social capital, and they do what I learned, wasn't my invention, I read it somewhere, that they do 3D jobs: dirty, dangerous, and degrading. So their spiritual manifestations are mostly at home, where many have altars, they have prayers, they have offerings, offerings that are representations in the form of altars in their homes, or in church attendance, like faith congregations. That can be a safe place to be and recreate community. Many churches in California provide a sanctuary for these undocumented immigrants for some times, but I don't know how it is in Indianapolis. And so right now, many of the churches in San Diego have lost their status as sanctuaries, and ever since the previous government. So there are many forms of recreating community, and it's important because community has healing effects. And so I have some photographs of people, dances from different parts of Latin America. But I wouldn't want this to be seen as a stereotype, because you would hear if I remember when I'm talking about our community, is that we sometimes have offered Mexican dances, to learn Mexican dances to our people, and they go, "Oh no, we don't want Mexican dances. We want Tai Chi." And they're Mexican, right? So they want Tai Chi. So we're really multicultural in many different ways. So immigrants lose a large part of social capital, and many studies show the power of rebuilding community. Why? Rebuilding community increases social capital and protects against depression in women, alcohol abuse in men, and gang involvement in youth. In our free clinics with underserved, isolated immigrants, we provide a space for gathering that really has, on reflection, I realize how much perhaps what we do has some spiritual aspects. So it's a community support and empowerment group at the student-run free clinic at the University of California in San Diego, where it's different from group therapy. And it is different from church, but it is a place of cultural safety. and it's a place of great confidentiality. For instance, one of the social workers in our clinics had wanted to start a domestic violence group. And the women, when I was talking earlier about cultural safety should be defined by the people that we are trying to serve or we're trying to coordinate services for, several of the women said that they did not feel comfortable in the same community to really disclose issues of violence in a group when they didn't know whether they could be gossip in the neighborhood. So we had to find a different setting for talking about those issues. So, and what do I call it? Why do I call it different than group therapy? Well, first of all, the weekly participants are the people that I'm talking about. It's drop-in. It is, you don't make a commitment to come to this group for a number of sessions. You come in when you want to, and it's open, for many years, open to any of the women that are come to the clinic for health or mental health. So they are, and the people who can attend are also, I don't know if you could tell in the previous photograph, I was there and there was also a couple of the medical doctors, and anybody can come in because it's a healing group for all of us. The facilitator is a promotora, which is an experienced community member, somebody who has lived in the neighborhood, in the same neighborhood as the patients for 25, 30 years. And so they really are the clients who are the experts that help each other. But what I find when I'm saying that perhaps it has some spiritual aspects is I'm finding the topics for discussion are always healing topics. They have to do with forgiveness, with gratitude, with self-care, with compassion. And then once every 2 weeks, we also have crafts. And once a month, there's like a potluck, and many of our patients bring their foods, and the group is in Spanish, right? So this is our promotora, who is Isabel, who has lived in the community for 30 years. And she says, today, she's the one who facilitates the group, so she starts with a theme of gratitude this week. And so often, she really is our trust bridge for medical and mental health with the community. She will be the person who will say to somebody, oh, you're being referred to mental health. And you will see Celia, right? Or you will see Sol, or you will see, and I assure you, you're in good hands. So, when I have a chance, I will talk about, our ideas about stigma probably tomorrow afternoon, because stigma, we could stigmatize our patients by saying that they have stigma of mental health when we're not really providing the services that are equitable. So Isabel brings readings, that she has an entire collection of sheets with various topics that have psychological impact, which are probably spiritual topics, and it's an approach that in some ways, if you read Desmond Tutu's book, The Book of Forgiveness, you will see that it has similarities with it, because many times what she says to our group is forgiveness does not mean accepting the abuse. Doesn't mean that you've been hurt, that you're supposed to forgive that person. But forgiveness is coming to terms with letting go of your hate or your distress for your own sake, for your own liberation. Okay? And so I want to show you some testimonials of the people who come to the group. And the first one is from a woman called Esperanza, which means hope in Spanish. And the second one, I think, is from a woman called Socorro, which means help. And it's interesting that these two women, who are called Hope and Help, they're the people who were very instrumental in wanting this group to take place, and they've been some of the best attendees of the group. Okay? And so the testimonials are in Spanish, but I have the translation. So you could follow the translation easily. What I find really interesting about what Esperanza says is she says, so that you could diminish your fear, right? And that you can go ahead in life with less fear. So how did Esperanza conquer her fear? Another immigrant member of the group said to the group, and said to Esperanza, fear is like a big red or black balloon. It's ominous, but you have to shrink it. You have to make it smaller. You have to make it paler. So Esperanza said that her fear was like a big, actually I think the other woman said that for her was a big black balloon. So she said, no, mine is like a big red balloon. It's really like it's going to attack me. There's going to be blood. There's going to be, and she was talking about violence really. And so, she had to shrink it to make it paler. So what she said was, I cannot really let it go completely, but I'm going to make it smaller, I'm going to make it pinker, and I'm going to put a leash to it. So I could hold it or I can let it go, depending on whether I need the fear or I don't. So, and let's hear another immigrant group member. I think now is Socorro, and so. So the interesting part about this is, like, remember, she's saying, I don't ask my family to change anymore. I'm changing myself. This feels almost like a therapy situation, right? Where people say, no, but that would never happen in the group, that people are saying to each other, you have to, you have to work on yourself. I think people sort of arrive in this idea that I can have more of a healing effect on me and on others if I don't demand change on others all the time. And so then we have people who really don't. Socorro does mention God, but Irma doesn't. But let's see if that would work. I don't know. I'm not sure. That probably it got disconnected. But you can read it, right? That before coming to this group, I didn't know how to control my anxieties. I had a lot of problems on how to talk to my children, with my husband. I feel like a different person with peace and hope. Okay? And so since I have the support of this group, now I know how to control myself, how to value myself before I did not know. And it's like a family here, and that is something very beautiful. So it depends on whether you think this sense of family and beautifulness is part of spirituality. But I'd really like this. She died about a year and a half ago. She was our oldest transnational, separated from 6 of her children in Mexico, and having 6 children in San Diego. So she always went back and forth. Because she was an older immigrant, she did have papers, but she became our wise elder. She told us about home remedies in a medical clinic. She told us stories about washing in the creek and using stones. She has the sweetest, most wonderful, really peaceful disposition, all cooking methods. Everybody loved her, and everybody was delighted to hear her, and she probably was the most decolonizing experience, for the group, because she had so much knowledge. And one of the things that the group had used for quite some time is a book recommended by one of the young physicians. It's a book of Toltec wisdom that you can get in Amazon, and where it has the 4 agreements that is a practice for your personal freedom, for liberation. And those are the 4, and we usually discuss those a great deal, like be impeccable with your words. What does it mean? Be respectful, be careful with what you say to another person. Do not take anything personally, because maybe something is happening to the other person, and maybe they're not attacking you. Or do not make presuppositions, be curious, and always do the best you can. So Miguel Ruiz is a Toltec Mexican person who is an author of neo-shamanistic text, and his work is best received among members of something I didn't know about. It's called New Thought Movement, that focuses on ancient teachings to achieve spiritual enlightenment. And as you probably are all knowledgeable about this, a lot of work is being done right now in the mental health fields to begin to incorporate more indigenous knowledge. So Miguel Ruiz is listed as one of the 100 most spiritually influential people living in 2019. And he's being compared to Carlos Castaneda. So the group also does a lot of crafts, and they are, Socorro, who you've seen, she is really very, very good with crafts. I mean, excellent. She can do very complicated things with paper and collages, and so she leads the groups in many ways with that. So you can see the simple topics, one word, and art materials, or collage, paintings, drawings. And there's one that I particularly like, and that was Isabel's idea, that is called Your Treasure Box, La Cajita de tus Tesoros. Well, this is, Your Treasure Box reminded me of the Suitcase Project. I don't know if you're familiar with the Suitcase Project for refugee African children that are affected by war and displacement, and they're given an empty suitcase. And to do artwork inside and outside of the suitcase, which has similarities with the box. So, and it's a healing approach, because the outside is what you show to the world, and the inside are your treasured memories that you may want to share by opening the suitcase, or you may want to keep just to yourself. So what I found really interesting about one of those articles that I read about the suitcase, and I was in Canada, so I actually did see an exhibit of the suitcases, was that the children did not want to tell many of the stories of trauma, many of the stories of feelings that they had tied to difficult experiences. But, children are very smart, and they're very aware of what you're being asked from them. And so one of them says, well, I don't want therapy, but, I got this therapist, and she kept on wanting me to talk about everything that happened. And so finally, I decided to just cry. I cried a lot, and that made her happy, So, yeah. So it is important to remember that whatever work is done, the needed emotional experience, emotional distance, has to come from the people that you're talking to, and not be forced to talk about trauma, So this, you see Socorro and doing the crafts, and that's what the clinic looks like, and not the one on the left. The one on the right. The one on the left is once a year we have a celebration where crafts are sold, and food is given, and many people who donate money to the clinic come, and so actually the money gotten this way, which is it gives back from the support group to the clinic by having things like water and the clinic, and sandwiches, very simple ones, that for the students and for the patients. So this is probably vanity on my part, because one of the times we did masks, and the second one is mine, on the Day of the Dead. So, so the learnings from the group are, connecting spirituality with social justice in the community, the ones that I could say, well, this is maybe what we're doing. The value is combating immigrant isolation, creating a place of safety together, and patients and professionals talking about everyone's life problems, reduces stigma of mental health referrals. I just remember, actually, that one of the times we talk about all these topics of forgiveness, gratitude, empathy. One of the times it was right after Mother's Day. So we were talking about Mother's Day, and the director of the clinic, who loved to come to the group, said, oh, yesterday or this week, was Mother's Day. And I have 3 daughters, and one of them didn't call me, and I don't know what to do. Should I tell her, did she forget about Mother's Day, or does she have something against me? And this, when you're talking about decreasing stigma, we're all human, we all have problems. And I think part of the message here is, like, why can't we just talk about our human? What is this idea so firm and rigid we have about dual relationships? Sometimes sharing your humanity it's okay, right? So, and what we don't have to disclose every aspect to have healing effects. So, and one of the things, for somebody like me who's been in the family therapy field for such a long time, and I always believed that family transformation can only come if you have the entire family together being interviewed. Well, this group really has taught me, because so many women said, including Alejandrina, right, the 86-year-old, like, I come here and then I go home and I tell them what we've discussed here, and it's changing my family. So it really also shows the power of individuals to bring topics of discussion that could be transforming to families. And the group has some spiritual rituals, which I think those topics are. And they have some religious rituals that some people share and others don't, but we all respect each other. So every group meeting ends with a circle, holding each other's hands in person, or reciting. Right now we are doing it via Zoom, Our Father's Prayer or the Lord's Prayer. So not all of us say the prayer, but that is completely accepted. So I also believe that when it comes to community and spirituality and social justice, we could amplify meaningful engagement beyond the healing community space itself. And so I decided, and it was a very big learning experience for me, a visit to the Mingay Museum of Folk Art in San Diego, and was able to get a bus to transport about 15 people to the museum in Balboa Park. And so, because this particular visit had 2 exhibits that seemed to fit very well with the group. And one was an exhibit of Sonabai. I don't know if you know who she is. Sonabai Rayawar is a remarkable self-taught artist, Indian, from a very small town, I think outside of New Delhi, who as a young bride was forced by her husband to live in total isolation for 15 years. During that oppressed time, she really did not see anybody except her husband and their one child, their son. So separated from the outside wall, Sonabai populated the interior mud walls of their hut with very colorful, whimsical sculptures that were created from her own vivid imagination. They looked like that. She invented a style that was all her own and was unique in Indian art. So when her confinement ended and villagers entered her home, they were outstanded by this vision, And Sonobai's reputation spread very fast, and she caught the attention of the Indian art world and expressed, her own vision in the face of great adversity, and actually ended up improving the economy of her small village because people started coming to buy art from other craftsmen that look similar. And so the other exhibit in the museum was the Trees of Life, which is very typically Mexican folk art, very, very complex ones. And these were awesome, incredible pottery work by men and women with vibrant colors, vibrant shapes, many with very religious and spiritual meanings that the clinic women were able to make meanings out of it, more than some of us that couldn't. But going to these exhibits was beautiful, and yet it was an extremely anxiety-producing lesson for me, and maybe for them too. Well, I took this group of women on a journey to a Central Park that they had never dared to go by themselves. And I thought they were safe. But by going with me, I had carefully planned it. I had secured that a bilingual museum guide would meet us there. But we went on a Tuesday, that was a free day for the museum. And as we walked in, we were stopped and asked for IDs. And so I was like, why? Why are you asking us for IDs? Well, you're coming into the museum, we want to see your IDs. And there were other people just walking in, tourists, white, blue-eyed, blonde hair. And so I pointed out two blonde, blue-eyed tourists who were just before us, and they went in without having to check in. So the front desk insisted that we could not go in. So I had to call the museum guide, with my phone and said, could you please meet us? So this museum guide came and said, oh, Dr. Falicov, yes, we have a date, right? So that then facilitated it. So, but I reproached myself a lot. I just said, really, should I have done it? This social action in pursuit of justice really can be very risky for undocumented immigrants. I don't know how it is in Indianapolis, but we have a border patrol, and we have ICE in San Diego. And so, I think many people, who don't want undocumented immigrants around may use their power to really stop them. So we must ask first, what is the benefit-risk ratio of social activism? When is it safe? When is it unsafe? When could it even, including in therapy, I know it's become, very current to think of social action in therapy. But again, is it something that we could do, that we have to connect with the level of risk of the people that we're working with? So our contribution can be collaboration in creating a safe space and carefully chosen consensus for advocacy. For example, giving information about BAWA, the Protection Act for Violence Against Women, is social activism, and we should do it, right? So, but I learned a lot from this because you probably are familiar with the idea of vicarious traumatization. So how this museum visit ends by expanding my boundaries. I'm not sure whether it expanded the women's boundaries, but personally and professionally. Why? Because, in recent years, I get a number of emails and phone calls, or people who find me through LinkedIn and say, could I talk with you because I want to go into psychology or into family therapy? And one of the things that surprises me is that sometimes I'm asked, or with some frequency, I'm asked, how can you stand working, with so many situations of pain and suffering? Doesn't it cause burnout? Doesn't it cause vicarious traumatization? And so, but what was interesting about this situation for me, and maybe in other situations I have experienced, that the women's response was to me, was to say, Celia, you're right. It was definitely wrong the way they treated us. But, so you're right. but they cannot take away from us the joy of seeing such beautiful things. Okay? And so it taught me a lot about this idea of vicarious resilience or resistance, the witnessing how clients cope constructively with adversity suggests that we can be potentially transformed by our clients' resilience, by our clients' resistance to injustice. You know? And so there are costs of care and compassion, but maybe there's also, you know, some positive effects, some things one can do by hearing our patients' experiences in terms of reducing vicarious traumatization. So when I told the experience to the MFTs at the clinic, we have 6 volunteers that really give their time, you know, they give the time away from their private practices. One of the clinic volunteers, a wonderful MST who is a narrative Latina therapist, who you see her there as the second to the left, she said, why don't I do a tree of life with the support group? You know? And it was an absolutely wonderful experience. You see this woman on your right side. Her name is Juanita. Well, she was a very shy woman in the group, but during the Tree of Life, she perked up, and where she shared her tree. And so people did their tree that has, you know, branches and trunks and roots and leaves, and they shared their life story this way, or what they wanted to share, and they liked it very much. And this man, who's so very well dressed, he comes to every Tuesday to the group. He takes a bus, and the bus is over 1 hour. And why does he come to the group? He told us, is you know, men are allowed to come, but we have many fewer men that come. But for him, the group is a form of healing, because he witnessed and perhaps perpetrated a great deal of violence as a young man and promised to eradicate violence from his life. And he feels that the group helps him in doing that. So, and I just want to mention briefly a Mexico City-based immersion education program that I was involved in. I was invited to collaborate in 2010 and 2015. And most of the students are second-generation Latinx students who know little about the countries of their parents. So the program was based in Mexico City, but we traveled to small towns in Oaxaca, where many of the student parents migrated from. The reason I want to show you this is because the Tree of Life was taken to that program too. And so the program uses critical pedagogy to develop multicultural competencies and expands the clinicians' understanding not only of their patients' cultural and structural influences, but of their own parents, which many times they don't know. So that's me with a tree in one of the small cities in Oaxaca. So we use the Tree of Life with school children in a rural school. Children love the Tree of Life, where they put fruits, animals, flowers in the tree to represent their lives. Perhaps stimulating their spirituality or at least their surroundings. But there's another reason I wanted to show you this. The tree originally looked like that. And so we all were given T-shirts. So I want to show you what my T-shirt says in the back. So my T-shirt, and everybody's T-shirt, said, to achieve a psychology of liberation, we must first liberate psychology. Those were words of Ignacio Martín Baró, who was a Spanish Jesuit priest and a psychologist who adhered to a theology of liberation in El Salvador, even though he had been born in Spain, but he went to El Salvador and was during the Civil War and was killed in 1989 for his speaking truth to power and using the church for political activism and social change against oppression. So and the reason I wanted to show you this and sort of circle back to Ricky's case was because what did he mean by liberate psychology? And to begin to answer it, we need to go then to the macro level, to connecting spirituality and social justice with courageous engagement at the macro level. And so he said that commit to reality, address social injustice, and honor connection. And so liberation psychology is a body of thought and practice focused on the experience, knowledge, and actions of those who have been excluded or marginalized. So liberating psychology means decolonizing it. So with many writings and books with the title of Liberation Psychology, and that talk about what colonizations mean. And I'm not going to spend a lot of time on that, but it's just the idea that professionals imposed a dominant construct as normal and therefore right, without awareness that it's not a universal. So let's for a minute look at the diagnosis of praying as fatalism. Remember, in Ricky's case, the doctors and the nurses thought that he should stop praying because that was fatalism. What they meant was that it was resignation, it was conformity, it was pessimism, destiny, you're born to suffer. And what I found really very interesting in Ignacio Martín Baró is that he has a book of his writings was collected after his death by psychologists who practice psychology of liberation. And he has an entire chapter on something he called the fatalism syndrome. That is a common theme to describe Latinos, including in cultural competence courses. So this is what he means by liberating psychologists. He has one chapter in that book called The Lazy Latino. So we know that that's a stereotype, right, about Latinos. The mañana idea, the big sombrero, sitting in a corner, taking the siesta, because it's like, and what he said is that fatalism, by always talking about fatalism as destiny, as being born to suffer, it confirms the stereotype of Latinos being lazy. So that there is a political utility to fatalism, but the impossibility of social change. So he made a real political analysis of some of the stereotypes about Latinos, and I think it's very important for us to consider that seriously, that it could be that fatalism is a realistic, resilient acceptance of the impossibility of changing many things because many oppressed, marginalized people don't have the power to change their situation. And so maybe it is realistic not to struggle against the impossible, but it also, I never had thought about possibly whether it had a political utility. So that is when we look at the structural differences, we could consider, does it have sometimes our stereotypes a political utility? Let's now look at the macro level, and I want to see how I'm doing with time. So I will talk for maybe another 5-10 minutes and then like to interact with you. So at the sociocultural level, this is at the macro level of policy, right? And larger societal structures. So I cannot do much about that, but my sociocultural insertion is in the professional world of training younger people to work with patients or clients that are suffering social oppression. So this is an area where I can share my experience. Is my involvement in integrating spirituality and social justice at the macro level is at the student-run free clinics, which means by run in this means we wish that it would be called student-led, because that's really what it means. The students learn how to deal with an underserved population in every aspect, from throwing away syringes to really being able to talk to people. But what I will not describe the mental health services except to say we have been extraordinarily fortunate of having wonderfully committed a group of volunteer people who are bilingual, bicultural, and that give their time. So, but I want to spend my time talking about something that has been happening in the last 3 years since the pandemic, and it's called the Fireside Chats. And so I'll just show you very briefly now the location sites of this mental health program. We started in a trailer. For 16 years we were in a trailer, and because access is very important. And now we're in a school grounds, and we were really very flexible, let's say very, very flexible. In the trailer, we used the same room as file cabinets, pharmacy cabinets, with frequent interruptions, with knocking in the door and coming in the middle of a session, or outdoors. And we had one room, and everything else was used by the medical students and patients. So, and now we have been donated time at 3 churches, and we use spaces like a therapy room in the main pulpit, and with one corner being used for acupuncture and the other for therapy. So our motto is people over place. So all of our students, both the medical students and the psychology or the mental health people who are a variety of MSDs and psychologists, they know that we have to learn about culture, structural issues, and family and community. But what I want to talk about for just a few minutes is a fireside chat. Because I believe that all of you can have fireside chats. You don't have to be at a free clinic. You have to be in any kind of community settings where a fireside chat, which, some of you may know that it was Franklin Delano Roosevelt that invented the fireside chats on the radio during World War II in the United States, to sort of talk to people in fairly transparent ways about what was happening and what they could expect and the types of sacrifices they needed to make. So one day, just as the pandemic was breaking, and we have most of our patients are essential workers, they were, many of them were dying, and many of them were people who were dying in their countries of origin. So a medical student who's interested in psychiatry, family medicine, psychiatry they have a big connection, and several students want to become family medicine with a specialty in psychiatry. She asked me, she said, how about if you meet with us in a fireside chat and we can tell you some of the problems that we're having with our patients, and you can tell us what to do. Well, it became much bigger than that, and partly is because they're somewhat shy about sharing. Many of them are first-year medical students, and now it is an elective for first years. So what are they? They are places where people develop cultural humility. They need to understand sociocultural considerations when working with Latinx and underserved immigrants, and in contrast with their own cultural assumptions, our biases. Actually, this slide was part of a presentation by a medical student, and said, including identifying and interpreting idioms of distress, appreciating the role of religion and traditional healing practices, understanding and addressing stigma, and awareness of structural inequality. So the idea of stigma, as I said, is a very complex issue that involves us as well as our clients. And it is both relational and contextual, and not something that is a trait of others. So the students love the fireside chats, and some of them, from the very beginning, they develop guides. So they develop guides about how to make mental health referrals to our group that are culturally sensitive, that use a language that is, it's about problems and concerns. In some ways, it goes back to Ignacio Martín Baró in the sense of you don't diagnose with things like, you have depression or you have anxiety and we have to give you medication. But it's much more about asking, what are the problems you're having right now? Do you have work problems? Do you have family problems? Do you have housing problems? And so I would have never been able to do this, but it's a beautiful guide because they use Canvas. They're young and they know much better how to use these things. And so now there is this guide of how to make mental health referrals in the clinic. It's under Clinic Essentials, and so they have it for other medical students. So so you could say, what might the students who attend the fireside chats do different in relation to Ricky and his great aunt? Well, they would do many things differently. But one of the things that for sure they will not do is to know that prayers can have multiple meanings and that the meanings of prayers cannot be assumed in advance. Okay, and so it could not be assumed that it was fatalistic, that it was pessimistic. So our students learn to ask the multiple personal meanings that prayers may have. It could be, it calms me down, it gives me hope, it gives me strength. So what did praying mean to her, to the great aunt? Was it any of these things that I wrote that have to do with hope? Hope and faith for restoring the child's health, hoping for a miracle, praying for Ricky's soul. We don't know. But by asking, our students learn that some people, actually one of my patients said, my prayers are the only thing I could bring with me. Everything else was taken away. But my prayers, nobody could take away from me. Yeah. So, praying as, tapping internal spiritual strength, we've heard many people saying that they were very moved during the pandemic when they received a free tablet from the clinic because she wanted a tablet so that she could connect with the prayers of her Christian church with the singing, that she could do her housework with the singing in the background. So receiving this was a form of equity for her, right? So praying, we cannot know in advance, right? So I had a situation, again, it was my patient, that was very depressed over an impended leg amputation because of a very advanced diabetes that she had not been able to take care of. And it wasn't her praying, it was the praying of two sisters via Zoom that allowed her to be able to accept her leg amputation. Yeah. So we really don't know so we always say to our students, ask, do not assume. So we should have asked about Ricky's mother, right? The doctors, the nurses would say, oh, you've been raising this child, and so how has it been for you? Well, Ricky's mother had been deported, and when he was a baby. But because he was born in the United States, he really had the possibility of staying. So his mother made the very difficult choice of leaving him, thinking that she could come back. But she never did. And we don't know really what happened to her. Some people undertake the journey again, but they die in the desert. So I think that we really need to ask. We cannot. So how often clinicians ask about spirituality, religion, and traditional healing? There are many, many openings from our patients, and we tell them that. So for instance, since many of our doctors are not Spanish speakers, but we have translators, we have interpreters. We have one of the classes is how to collaborate between the interpreters and the staff. And I asked the interpreters, so when a patient says, God willing, or Dios primero Dios, or do you translate it? And they laugh. No, they go, oh no, that's what my mother and father always say, or that's what my great aunt says, or that's what, and so they don't even know how to translate it, but it's important because it's an opening, right? It's an opening to know the spiritual or the religious life of patients. So let me finish by telling you, in truth, that we always taught in the medical school a biopsychosocial model. And it's only very recently that this was very good, to understand that we all are part of psychological, biological, and social issues. But recently, and I only discovered this while I was working for this presentation, that many people are using a biopsychosocial spiritual model. So I want to finish with that, and thank you very much, for listening to me. And we have about 15 minutes or so for questions you may have or comments, or so. Okay. Okay. So, is there any takeaways or something you want to think further or something you want to ask me? Yes, you do.
I'm curious, when you say idioms of distress,
Yes.
what do you mean by that?
Okay.
Some examples of that?
Okay. Well, there's a lot of indigenous folk healing things, like, if you know in Spanish, they would be susto, for instance, which is a different word for panic or for trauma but it's not identical. It's not like the same wine in new bottles or something. It has its own. So susto is a very good example because it's very common. And so, for instance, many of our patients have diabetes. And if they are really open with you, or you manage to create a safe situation, you say so. Because most doctors say you have to have better diet and you have to have exercise, which is structural, not really competent, right? Because many poor patients, many people that live in impoverished situations, they don't have access to healthy food, or they don't have a place to exercise every day like middle class and upper class people do. But if you go further, including the second generation, and you say anything else that you think is contributing to diabetes, they might say susto. They might say, well, my brother was taken away by the police, or my son is in jail, and that, when I heard about it, I didn't expect it. I didn't know that he was, being courted by a gang, so that's one of them. Empacho, is another one that has to do with whether you have a stomach ache or, there's something. I think the body-mind relationship, the duality that we have so clear in Western medicine, is less clear in situations. Even myself, who, I, as a child, we visited, folk healers, curanderas and curanderos, which are people in the community that perform different types of healing rituals. That it could be with ashes, or it could be with things, I don't know what to call them. Maybe you all know more than me what the translation for ventosas is, which are cups. I think some Eastern religions also use cups, or some people who practice yoga, they use heating cups for your back, and so that's supposed to make your lungs feel better, which probably they do, but they're not accepted in medicine, as no doctor is going to recommend cupping for here, yeah. But so those are idioms of distress, and people sometimes say my heart aches, or my head is burning, Sometimes many people who work in domestic situations would say, I was ironing, and then that was very hot, and then a cold breeze came, and that's why my hands are now have a rheumatoid. Doctors will call it rheumatism, but they would say, no, I have cold hands because it was a reaction to being hot and cold. So sometimes people just say, I was hot and cold. So those are idioms of distress that medical students should really be aware when people are saying things like that instead of dismissing it. I took a person that by every means everybody would think that he was going a psychotic break. I took him to the county hospital, and he had told me that he had seen a curandera, which is a folk healer in the neighborhood, and that she had said to him, I think you need to see a psychiatrist because I've done everything I could. But so then when I was telling the medical resident at the county hospital that this patient had seen a curandera, he was, don't talk to me about that. It was like, and so it was important to respect it because the person had been trying to heal himself in some ways already, okay? So idioms of distress are usually taken care of with more indigenous folk approaches. That folk is now considered to be a somewhat negative word, so I think it's called traditional healing, okay? Any other questions? So, did you learn anything new? Or yes, okay.
The question is mostly just kind of highlighting, and I really appreciate you sharing about the groups, with the women coming in, because I can see the healing within the relationship and connection. I mean, I lived in Mexico, I lived on the frontera as well, in Laredo, and so you had that in the Spanish-speaking churches where you have women's groups, and in many ways they did similar things that you're doing, and I was like, I see that, like, I know that model. I mean, not obviously right, but I'm like, I see that, and I've seen it in person, and it is extremely healing.
Yes.
To have that, and so I just wanted to point it out. That I just love seeing that.
Yes, the women are moving, aren't they, in what they're saying? Yes, yeah.
There's so much resiliency and so much, like, even women who would have thought, like, by all means, physiologically are not supposed to be working because they're a disability, but they're so active and so bright.
Yes, yes, yes.
They're supportive of each other. Like, talk about, they would do, for our group, they would do like fundraising and they would keep the money moving.
Yes.
And they continue to provide for their community. So I think there is something to be said about that.
Yes, yes, yes. Oh, thank you. Thank you so much. No, I completely agree with you that they give back a lot to their and they form communities. Yeah, and so anything else that you want to highlight about the presentation? Something that I could take away with me that you liked or you felt that maybe I should cover more, or so.
I had not heard the term cultural humility,
You had.
so I appreciate you talking about that.
Okay.
I think that's something I need to become more familiar with.
Thank you. Yes, I think that we have to rethink the idea of cultural competence as we are going to be experts on others, without looking at what we bring, So it's a matter of self-reflection. Yeah. And it's a process, So, any other comments or? Yes.
I have so much to say, but
Okay, Andrea, right? Yes.
but just to highlight one thing that was very meaningful for me is when you said that prayer was the only thing that they brought with themselves when they immigrated here. I have a connection to that because I was an immigrant with my mother as well, and yeah, definitely prayer was one of the only things that we could bring with us on that journey, and that's ours, right? Like nobody can take that away.
Yes, yeah. So that's very important, and nowadays there is more and more research on the value of prayer as a form of meditation and as a form of, inner healing, or at least, peace. And so I think it's very important for us in the helping professions to know about it and to inquire, not to assume that we know. So, yes.
Well, I could just listen to you all evening. This is so delightful, and this is my fireside chat, so maybe a chance to be connected with you and many people that I know from the past. So very great.
Well, thank you so much for coming and for sharing your experience. Thank you. Yeah. Anything else, or should we call it a night then? We're only a minute from 9 o'clock, so okay. Thank you. Yeah.